Check, check.
John, which was the laser pointer, the green thing?
The ones with the little light. The green arrow is forward, the red arrow is backwards.
This one right here.
That's the light, yep.
Yeah, that's you can try it.
Aim it at airplanes?
Oh,
Okay.
nice. So forward and backwards. Oh.
All right.
And then we can probably just I wasn't in the one. I know. I sent that email to Ellen. I sent the email to Ellen, and she responded back saying that it should be. So I'm just assuming yes, but if not, we can just wing it. Maybe give like 5 minutes after for people coming in and see. There's still some people coming in.
There's no plug in.
I'll plug in.
So like
For your
2:05.
computer? John had one.
Give it like 5 minutes. You got some people still coming in and signing to give credit. So is it get 2:05? You got some people go now?
Yeah, that's good.
Just coming up, so.
There's one right there. Will it reach there?
It's like a norm. I don't think so.
You can start drawing on the board, like the mechanism of action of buprenorphine. So you could draw it there.
Hey. It's not a bad idea. You can walk around the room.
No.
We'll do the best.
Well, I don't want it to die on you. Slide things down a little bit.
We'll be okay.
We don't have to be right in front of this either, you know, we can lift this down, that's fine. You wanna do that? John, you might move this down so he can plug his computer into the other outlet there, is that good? Just a little bit.
It's a common area.
Hopefully that works, like, we're still in the, are we still in the frame? Okay, thanks.
He's the better looking one. Make sure he's.
So the orange is off and the green is on.
Just maybe that.
Do you want to take this one, John? There's a meeting on that.
Yeah, that one's, this one's off. Oh, that's on orange. Yep.
Okay.
Yeah, cool. Give it 2 more minutes and we're good. Cool. I know that guy. You guys have questions, the doctor in the yellow shirt back there, we'll pick on, so. Good to see you, Chris. See what's coming, are we good, you think? Yeah, we're good, cool. Go. Good check, Nazareth. Good job. There's 1 or 2 more coming, so. We're okay to start, so. Sounds like you guys are the first wave, and then at 2:15 we'll get a second, so we'll get started to respect everyone's time, so. Thanks for coming. I know a lot of familiar faces. I was out last year, so I appreciate Norm covered last year for me, so not only is he a great friend and good PA, thanks for covering. And this year, Dr. Romankowski is not with us due to health issues, so Norm is back in again. So thanks, Norm, for being here, so. So I'm John Benfield. I'm a physical medicine rehab doc and a pain physician. I work in Utah Valley. I run a full cancer pain clinic with my partner, Dr. Hrushka, and Norm and several other colleagues. We see a lot of spinal pain, but also a lot of headaches, migraines, cancer abdominal pain. We do a lot of opioid management, including those on high-dose opioids. Those where there's a lot of chronic pain and opioid use disorder. So happy to be with you. Please interrupt us, ask questions. Any way we can help. If you have a case you want to run by where a slide reminds you of a case, please raise your hand and speak up. We want this to not only be informative but practical for everybody. Before living in Utah, I was practicing in San Antonio, Texas, in a multi-specialty surgical spine clinic, and then took a job here with Utah Valley Pain Management 6 years ago to do more comprehensive and interdisciplinary pain care. I get to work with Dr. Mendoza, who's here, one of our colleagues at Salt Lake Clinic. Chris has been a good friend and mentor since I've been here. And I'll interview the rest of us. So Norm, big round of applause. My wife was undergoing breast cancer treatments last year, so Norm stepped in for me last year, and then Dr. Romankowski this year. Norm, previously being to Utah Valley, was actually an ear, nose, and throat physician assistant with one of my friends in San Antonio. And so Norm and I met here at Utah Valley, but he works with Dr. Hrushka and I, but years and years of experience in the chronic pain world. He also does a lot of facial pain and head and facial pain and headache pain, along with migraines. But grateful to have Norm here. And who's next? Dr. Minori. Many of you know Dr. Minori. Dr. Minori runs Intermountain Health's Park City Spine and Pain Clinic for the entire Wasatch Back and even several areas, rural areas of Wyoming. His clinic's unique, and he gets a lot of complex and chronic orthopedics, not only spine, but orthopedic injuries with all the activities up there. And his clinic's unique. Several years ago, actually, was a pain clinic that actually had several high-dose opioid users, cancer pain, intrathecal pumps. And so Dr. Minori has a lot of expertise in how he's cared for those individuals long-term, but runs all of that. I'm glad to have Josh here. And then last and never least, but Dr. Hrushka is here with us today. Dr. Hrushka partners with me at Utah Valley Pain Management and also partners with Dr. Mendoza's clinic, but also does a full breadth of pain care. None of us just do straight injections. All of us manage opioids, high-dose opioids, buprenorphine patients, cancer pain. So please, if any of our slides you have questions on, cases in your clinic you're thinking about, papers you've read, please interrupt us. We want this to be informal and hopefully be helpful and practical. So I have to acknowledge, so this counts for you. This Core REMS course is based out of a Core REMS collaborative with the California Academy of Family Physicians. They offer, what's on this one here, a group of advisors that oversee the data and the slides that we're presenting. These are not created by us. We have gone through them, and some slides we've taken out because they're out of date with clinical guidelines in practice. But I only say that just so this is not our opinions. If some of the slides may be controversial with practice, please speak up. Some of this will present some of the information. We also know not all cases fit in the wonderful medical textbooks box of treatments. And then we have a lot of sponsors that you'll see up here that actually pay individuals to present this throughout the nation. It's a way to standardize, at least partially, our opioid, buprenorphine, fentanyl, medical cannabis, and chronic pain presentations throughout different states. And then I work with Intermountain to do this across the 7 states Intermountain's in. We'll present a lot of our data today for information that's specific to Utah. So learning objectives, this is nothing new and not unique to chronic pain, but looking at ways that we can specifically evaluate chronic pain, both from the subjective complaint, but also with physical exam, and how those interplay to get an appropriate diagnosis, but also to support and validate your patient's pain journey experience. Diagnosing, and we'll actually spend some time looking at diagnostic criteria for opioid use disorder. It used to be called opioid addiction. That pendulum is kind of slowly coming back where addiction's an okay word to use. We're not there yet, but opioid use disorder, substance disorder, opioid addiction, feel free to use those freely here today as you're asking questions. And then with treatment and education, I can speak for all 4 of us here. All 4 of us use opioids in our own practice. In a small population, those are ones we start. There's a large population that we take over and keep them there, taper them. And so our goal today with the treatment and use of opioids is to discuss indications, risk, and benefits, and the gray area that we all kind of live in with prescribing and treating opioids. We hope we can make that more clear for you. Or if you have questions, we're happy to answer those questions. And then how do you continue ongoing care for patients with chronic pain, but especially those on opioid therapy? It creates a different set of medical and legal risk that I think we're all old enough to admit that that happens. It's in our mind, how do we take care of these patients appropriately, but also how do we protect our careers and our clinics? How do you screen for patients that may need more help from addictionology, for opioid use disorder, or maybe they're not misusing the opioid, but other substances. So we'll tackle a lot of those conversations today. I'm actually going to take this out because I am not one who likes to sit or stand behind a podium. So if you can't hear me, let me know. So, and Chris is probably shocked that I have a collared shirt and dress pants on today too, right, Chris? So nothing new here. We have to review it. In Utah and most of the United States now, physicians, physician assistants, and nurse practitioners, our prescriber status is relatively equivalent. The education requirements for us to prescribe in our individual states, especially controlled substances, is relatively the same. Most states may vary by a half hour or so. Some are 2.5 hours. I think my Texas license is 2.5 hours. Utah, it's 2 or 2.5, or excuse me, for hours and years. And so, but most are around 4 hours per every 2 years. And that doesn't change in our state and most states based upon your license. Okay, now let's get in kind of the meat. They go from all business to all medicine, which is good. So obviously the big scary elephant in the room, we prescribe opioids, is how do we know which opioids and which patients may cause an overdose death or even an overdose? When we look at this from kind of a forest level and not a tree level, the big area that we see just kind of going off the charts, this is in Utah in the U.S., but really across the world, is synthetic opioids other than methadone. That's kind of literature speak for illicitly prescribed or illicitly obtained substances, specifically heroin and fentanyl. And then we're seeing evidence of both carfentanil and sufentanil being made illicitly. And we're seeing a higher rate of that actually happen in illicit drugs that people are obtaining that are actually where fentanyl becomes the filler. It's a filler med. It's put in there, beknownst or unbeknownst to the person that's buying or getting that medication. Heroin's the biggest one, but there are case reports and news articles where it's even been to things like recreational cannabis. And so fentanyl is the big one, with heroin being a second that we're seeing a lot of overdoses for. And that's fentanyl that's being illicitly obtained. It's not fentanyl. Go ahead, Chris. Not fentanyl that's being prescribed. Go ahead, Chris. It's included in both, yeah. And if you look at the newer data, like if you go to the state website, you'll see not only heroin and fentanyl, you'll see illicitly described stimulants, you'll see speed, meth, all of those are going with that same chart. So a little bit of mixed data there, but yeah. If you compared heroin and fentanyl, though, fentanyl is growing at a far faster rate than heroin. And from my understanding from this research, Chris, is if you had a urine drug screen, or in this case, it's an opioid death, so it would be actually the blood. If they had heroin and fentanyl in it, the fentanyl was counted, but the heroin may not have been counted. Versus the heroin line was heroin only. But because the patient's deceased, we don't know exactly they had it that moment. Yeah, so some skewed data. And it does exclude methadone, but the green line does not exclude tramadol and tapentadol. So keep that in mind. And the reason I mentioned tramadol, and we'll get into this later, is the MME in tramadol was actually doubled in 2022 with those CDC guidelines. Even though the chemical didn't change, we now count it differently. And Utah started counting that differently, I believe, in March of this year. And you'll see the Doppel. You may not have changed a prescription, but now you go check the PDMP report, and you'll see the MMEs doubled, even though the prescription didn't change. There's a debate on that. I'm not a fan of that because I think tramadol is a great way to rotate or wean someone off of a more potent opioid. I also think just because we count it differently, it obviously doesn't change the chemical of tramadol. But want you guys to be aware. The big thing in Utah, I don't think there's any of our slides, but I'm covering one of you guys' slides, is Utah, when you're over 50 MME, has a strong recommendation to make sure you're prescribing naloxone. And so if you run a tramadol prescription that was below that in February of this year, and you give the same prescription now in May, it may change how you're prescribing that naloxone from a legal perspective. Natural and synthetic opioids, those are prescription natural synthetic opioids. Think morphine, Norco, Percocet, oxycodone. We've seen prescribing rates of opioids actually be on an appropriate and steady downturn really since about 2016. If you were to hone in, though, on 2019 to 2021 through those COVID years, we actually saw a small bump in those. You'd also see a smaller bump in suicide rates, chronic pain going up. And we saw that in our own clinic. Those first 6 to 8 months of COVID, we actually saw almost weekly patients where our psychologists were dealing with patients that were suicidal. Go ahead. Yep. That's correct. Yeah. So you actually saw it going down until COVID. And then, and I'm not saying there's a direct relationship between opioids and COVID. I'm just saying we saw it go up. And then, yeah, we've seen this huge decrease now, 23 to 24. And they don't know why. There's some speculation is, and I don't know in that article if they counted buprenorphine, but they've made that a lot easier to go to buprenorphine, which in some studies, it is an opioid chemically. Some studies they count, some they don't. But yeah, we've seen that as well. And I would say consults coming into our clinic, we're not seeing as many on opioids, and I'm not seeing those doses of 2, 3, 4, 500 MMEs like I used to see 5 or 6 years ago. And probably a decrease in methadone as well that I've seen. So I would agree with that. So we'll actually get into this slide right here. If you trended this back to like 2018, 2019 on the Utah, we would be at, I think it was 56 to 59 prescriptions per 100 people. And they took the slide out, but where Utah really got on the map in the opioid epidemic is not only were we prescribing more opioids, we were actually prescribing more opioids at a higher rate. And as the rate went up, we prescribed more. The caveat to that is Utah was also very good in reporting their data to the CDC, where other states were not. So that data is not as crystal clear as they'd like it. But to your point, we're seeing those same trends over the last several years. And in Utah, we actually didn't see a huge bump between 2019 and 21. We kept having a steady decline down, which was really nice to see. And the state of Utah has done a great job in reporting their opioid prescription rates and their opioid overdose deaths. And we're actually trending between 2017 and 2019, we were in the top 5 when it came to prescribing. And we've seen our Utah death rate, along with the prescriptions, go down. That's declined. And Utah actually has one of the highest rates in the country of naloxone prescriptions. Whether that's correlation or causation, who knows? But it's nice to see both naloxone prescriptions trend up, and then our opioid overdose rates from both illicit and prescribed go substantially down. So, yeah, good job, docs in the room. So, all right, Norm, it's all yours. Move to Norm here for a little bit. Ask away, yeah. Yeah, so like people, yep. Yes, they don't have a graph, but those graphs do exist. So in the first group of illegal opioids, say illegally obtained fentanyl or heroin, let's take the fentanyl group. That fentanyl group is the highest of all of them. And then we get in this group of people that have a prescribed opioid that they are using illegally, say they're overtaking it. That's that. Yep. That's that next kind of piece of the pie. And there is a group, though, that has an appropriate prescribed opioid and is taking appropriately. We still see about a 25%, up to 25% overdose use, but we don't, and then I forget the deaths, and then I want to see the overdose use as taking prescribed is 25%, but I don't remember of those overdoses how many were deaths. But yeah, if you had to tier it, it's illicit, it's prescribed and using it appropriately, whether that's diversion or they're taking more than they should. And then it's those that are taking exactly as prescribed. There's still a risk there, but they're in the lowest, safest group. And then in that group, if you tiered it by 90 milligrams of morphine, and then 50, and then 20, obviously as the the dosage goes down, but also the pill count per prescription goes down. You see those overdose goes down too. Yes, they have a great graph of it that we share with our patients, so it is there. So if you bug me afterwards, I can probably email it to you. Yeah, great question.
Excuse me. Thanks. If I can just add to that, I think with a few years ago, in reference to how many people were dying from prescription opioids here in Utah, it was actually around 360, 361. And what we see is not so much a problem with fentanyl here in Utah, although we are going to be talking more about that, because, as he had mentioned here, with the heroin and fentanyl, and I'll be addressing that later on, we're seeing the mixture. A lot of people, when they're using heroin, they're finding fentanyl, they're finding xylazine mixed with that, and we'll address that more. But here in Utah, it's not so much the issue with fentanyl as it has been back east, but it's shifting its weight forward. Here in Utah, it's actually more prescription opioids that are finding their way, and often due to misuse with that. But before people got there, let's go just a little forward to that. It all started usually with pain. I had a young man in my office a while back who was 18, and he was actually there for opioid use disorder. We were there to help get him on Suboxone and help make this transition. We asked him where did it start, and he mentioned to me that it started actually in junior high. Someone gave him some opioids to try and help his pain. He was playing football, and with the young mind, he became addicted to it over time. He was willing to take more than he's wanted, and he was eventually, the hard part was even trying to look around our office to see what he could find. But other people were targeting him. His family divorced, and a gentleman in his junior high introduced him to heroin, and then he got set on a path that was really hard for him in his life. But it usually begins with pain. I had a lady who was asking me a while back, said, why am I afflicted? They'd hurt themselves. Pain has its own purpose. As many of you know, we see that with, my wife actually just texted me, she got bit by a spider this morning. And it triggered some tissue damage, some inflammation. She was showing me her finger, and with that, the body has its own way of responding to this. So with that, as protective mechanisms and inflammatory mediation occurs, this can actually then help with the body's actions to help repair and help get rid of the pathogen that's been involved, or even the tissue damage that's occurred, and we'll talk a little bit more about that. However, with chronic pain, this is where we start to see even so nociceptive involvement sometimes. We'll see that it really has no purpose. This is where the patients who may have injured themselves, and then it keeps going, and for some reason it's just not healing up. They may find that when you touch it, they're usually hyperalgesic, and then the steady state or worsening keeps going. We'll see this typically with fibromyalgia patients. Usually patients will come in, we'll say, well, how did it begin? They say, well, it started out with an injury, but then that just kept going, and eventually they found that other organ systems became involved. We'll see peripheral and central sensitization occurring with that. Now, we're going to kind of speed through this a little bit. Different types of pain, we'll see that nociceptive pain, this is your inflammatory response, this is your sprained ankle playing basketball, your low back lifting, trying to bend over, trying to lift a little more than you should. The body responds. Sometimes there's an inflammatory response. But then with nociplastic pain, we're seeing a little bit more of a response. This is your altered function. This reminds me a little bit of my son. Sometimes if you have little kids, my son, sometimes something would spark, and he became really sad, and then he'd start crying, and I'd come to him and say, well, why are you crying? He's like, I don't know. And he would keep going. And so we'd talk, and we'd gently try to figure out and calm him down. In a similar way with nociplastic pain, when patients have irritable bowel syndrome or stress involvement, sometimes that will actually start to change, and in the brain there will be some modulation or some changes that will occur, and we start to see again a hyperalgesia effect. Patients may report of low back pain, but they're not sure exactly what or how. It's just always there, and it seems to be worsening. You touch on their back, and they're very sensitive to that, and they find other areas in their body that are also responding. That is typically what we're going to see with nociplastic pain. With neuropathic pain, this develops when systems are damaged. We'll see this with a variety of conditions, everything from trigeminal neuralgia, posterior neuralgia, injury occurs, or stress response occurs, and then we'll see a neuropathic response. CRPS is a great one, but CRPS can also sometimes turn into what we call nociplastic pain responses. There's mixed pain responses where we have nociceptive and neuropathic. Very common, primary injury occurs, and then we have a neuropathic pain response in the process. A lot of this is basic, but in thinking about my wife, we want to just briefly address some of the modulation that occurs. Usually, whether it's a pinprick or a spider bite, an injury occurs, transmission occurs along the mixed fiber neurons that will go to the dorsal horn of the spinal cord. This will then transmit up to the brain. And modulation, this is kind of the telephone game. The body is very fast as it's producing this, but the signals, as they found in patients with nociplastic pain, some of these signals will get altered in the process, and they found that, like with fibromyalgia, these signals will then become very, how do you say, respond, I was looking for the right word. Huh? Amplified, thank you. I wanted to say hybrid, but an amplification occurs in the brain, and we see that on imaging with patients with fibromyalgia. So, but then the body responds also. The central, the brain center will then send endogenous opioids, neurotransmitters, including serotonin, and then norepinephrine. These will then try to help calm down the secondary responses that are occurring. Endogenous opioids are great at calming down the substance P, which is enhancing some of the pain sensitization that's occurring. Serotonin is also good at helping to calm, and norepinephrine often will work in conjunction with serotonin to kind of calm down that pain response. Now, mediators, when a tissue damage occurs or an injury occurs, the mast cell will often release histamine. The histamine response very commonly will cause inflammation, vasodilation, bradykinin and prostaglandins. Prostaglandins, as you know, are involved in the inflammatory response. NSAIDs will work to try and inhibit the production of prostaglandins and hence calm down the inflammatory response. You'll notice that substance P is also there, and that can also enhance the pain sensitization that's occurring, but substance P will also cause the release of histamine from the mast cells. Now, you'll see that CGRP is also involved. It's involved in migraines, but it's also involved in the pain inflammatory response, can also help to vasodilate some of these, the cells, and also work with substance P on that. Now, so CGRP is involved in the pain inflammatory response, but it's also involved in the brain with migraines. It's one of the typical causes they found with the they call it the cortical sparing depression response in migraines. Opioid receptor locations, why this matters. The endogenous opioids are natural pain inhibitors, will help to bind to mu receptors throughout the body. In the mu receptors, we'll find that they're in the brain, they're in the spinal cord, they're in the GI tract, they're also in the skin and the peripheral area. The periaqueductal gray, that's one of the modulating centers that helps to, you might call it the central command center along with the brainstem. The brainstem is area that will help with breathing and other vital organ responses. The amygdala, the nucleus accumbens, that's more involved in the pleasure response, the good feeling that we have after we've exercised, worked out, or even when we've kind of built those up in our system, or the opioids will also affect that center as well. Amygdala, this is also involved in some of our emotional and our stress response. The GI center, the GI tract, opioids, and even endogenous opioids can kind of help regulate that and will affect the regulation of this through our body. However, one of the problems we see with opioids is it can actually dysregulate this. They found that when opioids are used, the endogenous opioids kind of shut down. They stop, and we don't get the appropriate function. Matter of fact, multiple studies have been done that have found that when opioids are used, they're kind of taking over, and we don't have the endogenous response that we used to have. Now, with substance use disorder, addiction, we often find patients will sometimes come to us and they will say, my family member's concerned that I'm addicted. If I stop taking a substance, then I go through withdrawals and so on. What we have to explain to patients and try to help them, family members, understand that withdrawal is not necessarily addiction. But as the ASAM definition, I really like that. It's the continued use of drugs or activities despite knowledge of continued harm to oneself or others. And then continue, it says it's a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. I had another gentleman I was talking with, one of my colleagues. I was there to help him with, as we were getting him on buprenorphine, and I asked him his story. At one point, he found himself no longer just taking medication for pain. He popped 11 Norco in his system, and I said, "Excuse me?" And he said, "Yeah, I was 11." And he sort of noticed that he was feeling a craving, just a desire. We'll see that with patients with opioid use disorder. Has anyone ever gone through this criteria with their patients? Has anyone ever? Yeah. I've actually printed this out, and sometimes when I'm talking with patients on overuse, I found this to be helpful. To say, as we talk about, let's kind of go through, what do we see? Have you taken larger amounts than is expected or that was intended? That is important to see. We actually do pill counts, as we tell patients, not because we're police, but if we start to see patients taking a little more or one or two, this can sometimes be indicative that in future aberrancies might occur. And so we try to keep that, and we talk about safety and other issues with it. Sometimes there's a persistent desire, inability to cut down or control use. Sometimes the patients will say, "Man, I just can't get down. I find myself going back up." And it's not just because of pain, but they talk about the withdrawal and the struggle. Now, if it's withdrawal, we sometimes work with that. We taper patients down a little slower to try and get them off. But if I was talking with one member's family or a family member about a patient where if we start to see, well, how are they in their personal life? Are they spending increased time focusing on? Does their life revolve around it? How are they able to enjoy some of their natural activities? Do they like to go hike? Are they able to go get out of the house? But if we start to see this where there's increased time spent, recovering from the use of the opioid or making sure that if their life sort of revolves around this, that's another sign. How are they at work, at home? How are they with the family members? Is that affected? Do they feel ashamed because they're on it? Do they, are their social or interpersonal problems? Are their family members concerned? Do they see a different person that's acting or using? I had one person mention their family member would send them across the house because their interaction between their marriage was being affected. Physical hazards, reducing social work, recreational activity, we talked about that. Physical or psychological harm. You'll notice that tolerance and withdrawal are listed, but if that's all they have, that is not an opioid use disorder, and we'll talk about that with patients. So when patients talk about tolerance, they feel like, hey, this just isn't working as well, that by itself does not qualify, nor does a withdrawal symptom if you were to suddenly remove it. That does not mean addiction, as we had mentioned earlier. But if we start to see this, then we can, we see a combination of these, then we can incorporate those as well. The cycle of substance use disorder, let's talk briefly about that. The neurotransmitters, dopamine and opioid peptides, these are involved, these are sometimes the pleasurable response. neurotransmitters are involved, and we'll see that patients, when they get that response, they're going to, this is hence one of the reasons why patients will take more than is intended. And then we start to see a negative effect, a withdrawal, a shame. And when that occurs, we'll actually start to see the involvement of the cortical releasing factor and dynorphin that are involved with this. And then finally, we start to see the preoccupational anticipation response. Glutamate's often involved with this, particularly our learned behaviors with substance use disorder. Okay. I believe Dr. Hrushka. Or, no, I take it back. Dr. Benfield.
Stuck with me again.
Yeah.
Sorry, man. Thanks, Norm. This is an area I'm really passionate about. One of the reasons I changed my practice from San Antonio, Texas to Utah was the ability to join an interdisciplinary pain clinic. For the first couple of years out of my fellowship, I was seeing 30 to 40 patients a day. It was no time to, you guys know the story, right? It's no time to deal with mental health, no time to talk about opioid use disorder. If it wasn't an easy condition, we didn't have time to see them. And it just felt very inhumane, felt very unethical. And so the multidimensional evaluation of pain is, it's not new. It's been around for decades. I mean, as early as the 1950s and 60s, this was discussed. It's got great data, which we won't get into. Intermountain's big thing right now is proactive care or evidence-based care, whatever you want to call it. The way to treat chronic pain is by assessing all of the aspects of someone's life, and that's not lip service. It's one of the things that drives me the craziest when I go to pain conferences, see all these docs go up there, and I'm multi-specialty, I'm interdisciplinary, and you actually look at what they do. They put needles and scalpels in people's all day, which all of us do, and we like to do it. But that's like, if pain were a pyramid, that's at the top. Like, that should be one of the last things people go to, with a couple exceptions. Pain is also generally one of the only medical specialties that's named after a symptom and not a system. We're treating an experience, essentially. And not on here, there's an association called the IASSP, and they look at the international definitions of pain. And a handful of years ago, they actually changed it to include any emotional, psychological, or organic experience of pain, from Norm's wife having the spider bite to someone maybe having a fairly low risk, low velocity injury, like a fender bender, but having years and years of chronic pain. We have to take care of the experience, because that experience interacts but is also affected by what's going on in their life, with family, intimacy, and work, psychological changes, either intrapersonally or extrapersonally, or in between people in their life, or even with you as a provider. And obviously function is a big thing, and function is actually a better barometer. I'm going to be the biased physiatrist here saying this. Function is a better barometer if someone is improving in their care than them reporting their own pain. And you've all seen this in your practice, right? Doesn't matter what you give them, how you treat them, that pain's always an 8 or 9 out of 10, but now they're walking 10,000 steps. I have a patient named Lisa that I treat. Lisa's a wonderful patient. She's on a very low dose of tramadol and ibuprofen. She had back surgery after a bad disc herniation in her late 20s, delivering her first child, where she had an L4 and an L5 disc herniation, with the L4-5 being fairly significant, where it's causing severe spinal canal stenosis. She had a fusion done at L4-5 with a disectomy and a cage put in. Those are the days where we're actually doing not the cage, the graft was taking out the posterior iliac crest. So a lot of crest pain with it too. I met Lisa about 6 years ago, and the third time I saw her, she came in. She has knee osteoarthritis, so it's pretty significant, but not the main pain driver. She came in and she couldn't extend her knee very well. And she thought it was that she had walked too much on a recent vacation to Germany. But as we did a physical exam, it became clear she had frank quadricep weaknesses at a 2 out of 5. Like, I don't know how she got in there. It was just her and her cane and her husband. And so we immediately sent her to the American Fork ER. She had a large 3-4 disc herniation that was right above her fusion. It was more than 10 years later. Unfortunately, it kind of follows the course for some people with fusions. And so Lisa, the same thing happened again 2 years later with an L2, L3. So Lisa now has an L2 to L5 disc herniation, and she has an L5S1 disc herniation now, or L2 to 5 fusion with an L5 to S1 disc herniation that's kind of just there, and it's kind of haunting me every time I get an MRI, and I'm waiting for that to get larger. Lisa's pain has always been a 7 out of 10. When I do her promise 10, we call her pre or post visits. But we've been able the last year and a half. Lisa has now walked every day for a year. Her meds haven't changed. Her pain hasn't changed. She's walked every day for a year. She walks 2 miles. And Lisa now can travel to Pennsylvania every quarter to see her sister-in-law, excuse me. So I only tell Lisa's story, not because I love treating her, but which I do. Her function for her is the barometer now. So when she says her pain is worse and she still gives me a 7, we actually look at her step count after she walks that day. So keep that in mind. It's a good barometer. Lisa also, over the last 4 or 5 years, has had some big family changes. She had a granddaughter die before age 1. She had another daughter that's on her 3rd pregnancy, and her pregnancy was very hard. Her daughter had eclampsia and almost passed away. She had another son and daughter go through divorce. And when Lisa's gone through those, even though she's very stable in her own life, been married for 30 years, has a job, same home, no financial stress or intimacy stress or work stress, you can see her empathy for other people affects her pain. And so when those things happen, we've now leaned on psychology. So I love the biopsychosocial model because it allows you to just validate and look at other experiences in people's lives. No, it's not lip service. No, it's not warm fuzzies. The same chemicals that give us depression and insomnia also give us chronic pain. We all know that. You know, that it hasn't changed. The analogy is lame, and I always give it to people. It's kind of like if we were making a baked good. You can make cookies, you can make bread, you can make brownies, you can make a lot of things with, and they all have a lot of the same ingredients. And unfortunately, pain's not much different. When we look, though, at the biological aspect of pain, so what conditions people can have before they have, so if you have these conditions before having what we call chronic pain, so pain lasting longer than 3 months that gets in the way of your daily function, and that could just be that it's hard to sleep, or it could be you no longer work, or you no longer work, you can't sleep, and now you have a divorce because your spouse hates you because your pain's so bad. It could be a lot of those things. They call these ACEs. That's not a commonly accepted term in pain, but adverse childhood experiences. Once they start developing pain or substance use disorder, if any of those circles around kind of the tentacles that would come into the main body, you have anywhere between a 60 and 170% increase at some point in developing chronic pain. And that could be chronic pain from something simple as you're out doing yard work on the weekend and your back starts to hurt. It's atraumatic pain, or it could be you got into a fender bender, or you have a big car accident. But your likelihood to develop chronic pain is a lot larger. And I don't know that any one of these are more likely to cause it, but we more commonly see it, though, with the depression, anxiety, suicide, PTSD circle, just because those conditions are so common. And we also see it a lot in the traumatic brain injury circle. It says fractures and burns, but when people get fractures and burns, where does the fracture and burn stop and the PTSD start? When they're large injuries. And so that gets in there. And I ran actually an HIV neuropathy clinic in San Antonio. I actually didn't see chronic pain in that group outside of like chronic peripheral neuropathy or neuropathy from the HIV or AIDS meds as much as I saw it in the behavioral health, substance use, and the traumatic brain injury. Cancer and diabetes, although they develop chronic pain, cancer can be, for many reasons, but in the pain world, can really sneak up on you. So we actually get a lot of patients that end up getting chronic cancer pain, usually in the form of neuropathy from treatment. And it ends up showing up actually several years later. I don't know the last several people I've done electrodiagnostics on for a cancer-associated peripheral neuropathy. On average in my clinic, it's about 7 to 10 years later. And so keep an eye on that. And so when you start to see neuropathy, even with or without diabetes, do that history screening for cancer. We don't see HIV as much in Utah as I saw it in San Antonio. HIV, I'd see develop the neuropathy a lot sooner than I see in cancer. You obviously see chemotherapy more than radiation, but you can see both. In that group too, though, if their cancer had a prolonged hospitalization, either multiple hospitalizations or one long one, there's also a huge overlap there with critical illness, myopathy, and neuropathy. So that can be kind of a big melting pot that develops chronic pain. Then the education, occupation, income, that's not unique to chronic pain, right? We see those social determinants of health, right? As education, occupation, income go down, we see a lot of diseases go up, probably because we're not meeting those people's social needs. And chronic pain is no different. The other one is very much kind of more of a tender one, and we do see this, is the unintended pregnancy or pregnancy complications or fetal death. There's huge overlap, obviously, with those experiences and just across the circles to the depression, anxiety, and PTSD. And so we get probably, would you say, Norm, or like maybe 3 or 4 times a year, maybe a woman that's going through something like this, or they just have a very traumatic pregnancy. You know, the pregnancy is successful, things go well, but they never had back pain before. Now their SI joint pain is terrible. They can't walk. It's just, you know, they have other things on it. So we see that a fair amount as well. So how do you start a conversation with a patient? And I'm going to divulge here. I'm always one of those doctors that hates slides that tell you how to talk to patients, because if you don't know how to talk to a patient, you're probably in the wrong profession. But we all have colleagues that maybe struggle with this. Let me give you both sides of the coin here too. The first thing I would do is don't react to the patient. I've seen a lot of, I actually had one this week. One of Dr. Hrushka and I's partner, Dr. Hilton, had a patient go to one of our ERs, and he was upset that Dr. Hilton wasn't taking care of his shoulder pain for a recent surgery he had. When I got into the chart, I realized the patient never told Dr. Hilton that he was going to have surgery. So Dr. Hilton never had the chance to take care of him. But what happened is both the ER physician and the orthopedic physician came in and didn't bother talking to the patient first. They saw that the patient had buprenorphine on his file and immediately thought that the medication was just there for only opioid use disorder. And if they would have read Dr. Hilton's last note 2 weeks ago, right at the top, it says buprenorphine being used for chronic pain and opioid use disorder. Patient may be having a shoulder surgery. Anyway, it escalated so much from these two physicians wanting to address the opioid use disorder, and some of them called me and not Dr. Hilton, but either way, but they approached him in such a wrong way, the patient, it set off the patient's PTSD, and I got called by the time the patient was threatening to kill Dr. Hilton. So it escalated so much, but it's like I would just, it's the old school approach, right? Sit down, don't look at your computer, talk to the patient, everything we all know to do. We should have a very low threshold to know when we see higher opioids or opioid use disorder in a chart. This may or may not be a patient that has unstable psychological health, but we should always approach it that way because that's where the win's at. Tell me what's going on. Why do you take these meds? Do you think about these meds when you don't have pain? The longer you've been on these meds, do you think about them more? Do you think about taking them earlier? Do you wake up and the first thing you do is take an oxycodone? You know, do you wake up at night and from a sound sleep, do you set your alarms to take your meds at night? You know, I won't call them red flags, but I say yellow lights. So, and then the terms to avoid and the preferred terms, these are based upon the core REMS faculty. If you look at the American Society of Addiction Medicine, there'd probably be some large disagreement here. So the condition opioid use disorder or substance use disorder, that's like the clinical ICD-10 diagnosis. However, the specialty is still called addictionology or addiction medicine. And so I would say both are okay to use. If you want to be really, you know, sensitive with the patient, opioid use disorder, but most patients don't understand that language. They do know what the word addiction uses, so you may have to use them in combination. Drug-seeking aberrant behavior, I would say probably avoid those with your patient, but, you know, are you thinking about your drugs a lot? Do you dream about them? Do they not only make your pain go away, but do they make you feel happy? Do they give you energy? That kind of euphoria that we see with some patients. Addict and user is, dirty urine, those are ones we don't really use anymore. I definitely would not put them in your chart. It can paint you in a light as a prescriber that's like, you know, coming across as judgmental, even though you're not. It's in your chart, and sometimes the chart is what we get stuck with. Substance abuse as well. That's still a fairly commonly used term amongst addictionologists. In your note, I would say substance use. That gets tricky, though, because when that substance use is a prescribed substance, they're supposed to be using it. They're not supposed to be abusing it. So I would say with the addiction and the substance abuse, those are still fairly generally accepted medical terms. But if you want to be, medically legally compliant in your notes, I would use the preferred terms on the right. But the actual conditions for ICD-10 are opioid use disorder, and then substance use disorder is really anything else outside of opioid disorder and alcohol. So you can specify that if you'd like. The other preferred term, you have to be careful with documentation, is the testing positive on a urine drug screen. It's great if they test positive for a drug that they're prescribed. It's not great when that's an illicit drug or a drug they're not prescribed. I also am okay with a negative drug screen for drugs I don't want to see. But if I'm prescribing an opioid and it's not on your drug screen, then I don't like it. So I have a hard time with that one testing positive on urine drug screen. I would use the word drug screen as appropriate for the medications prescribed. There's a lot of inference. Okay, they're taking what they're supposed to, but not taking other stuff. If you see a note that says drug test positive, I just go look at the urine drug screen myself, because positive for what? I mean, if I give you a CBC and I was like, hey, the CBC's high, what does that mean, man? And so drug screens are the same thing, and especially drug screens now can test for a lot of different chemicals. And so you can work with your office to see which chemicals you want on there based upon your prescribing habits. I'm not going to belabor this point. There are lots of ways to take an HPI on someone in pain. The ones I like are, where's your location? How long has it been going on? Where does it refer to? And one they don't have up here, I like to know any big red flags. Are you having weakness? Have you had a history of cancer? How quickly did this come on? And there are any of these symptoms that really concern you. I had a gentleman when I was either a fellow or a resident at the San Antonio VA, and he came in pretty fit, pretty healthy guy. I couldn't pick up a lot of weakness on exam, but he felt like his big toe, just when he walked on it, he couldn't push off as much. And he was a very reasonable guy, so it's kind of like, this is a reasonable guy who's really fixating on this big toe issue. He maybe was 4 out of 5 on his EHL, but it was enough, it bugged him, and he had a lot of pain in an L5-S1 distribution. And enough where he came into the ER off of work, wasn't on any medications, and we screened his back, and he had actually a huge L5-S1, but he also had a really big L1, L2. So when I saw that, I went back and actually did more sensory testing around his rectal and genital areas. And he had conus medullaris syndrome. Because when they tried to, I said, when's the last time you peed? He's like, well, it's been like 12 or 13 hours. I said, okay, for a 25-year-old guy, that's a long time to go from peeing, And so he actually went and had an emergent decompression. And so location, how onset duration, and the ones they don't have on here, like which one of these symptoms is scaring you the most? How quickly did this come on? Maybe what were you doing 24 hours before this came on? Had another individual that I was planning on doing a procedure on recently, 84-year-old guy, has had chronic low back pain for decades. He was going to get a procedure. We actually put some trocars into the vertebral bodies, and we burned the basic vertebral nerve inside the spine. And in Jay's back pain just looked a little more chronic than normal, but his functions are declining. He could no longer walk up the stairs to his house. He could go through the garage, but he just didn't have the energy to get up. And so we scanned his spine again, and his prostate cancer had come back. And so he had just one little met above where I was going to go, and we were able to get him in to see his oncologist, and he's doing better now, and he'll get that procedure in 3 months. But pain, get into the nuance. The nuance is worth it. The other thing is, a lot of chronic pain patients are not just going to have one location. And sometimes they're very tangential. So give me your top 3. If I could wave a magic wand and take care of one pain complaint today, what would that be and why, And I don't say that to be belittling. It's just you have to kind of hone in on that. Then obviously alleviating exacerbating factors, especially if there's something new, a non-painful stimulus that is now causing pain. Like my younger guy is like, man, I just can't push off my toe. Get into that nuance. And then obviously you're going to want to take into account current emotional state, psychosocial state, are there coexisting mental health conditions? Those are nice to know, but I would be very cautious with as common as chronic pain is, especially spinal pain and headache pain. Be very cautious to jump to the mental health being the pain originator. It can be an amplifier, but it's often not what's causing the pain, it's amplifying the pain. Medical treatment and history, you all know the importance of relevant illnesses in the scope of chronic pain and opioids, obviously cardiorespiratory issues and any neurocognitive issues they may have. So like we see a lot of people as they get from their 70s, their 80s, or in their mid 70s, when they start to go and do assisted livings, they start to have family members take care of them. We see a lot of diversion when it's a nephew, a niece, a son, or a daughter. That happens a lot. We also have seen it at skilled nursing facilities where they don't have something that electronically scans the medicine, so we know a date and a time. We've seen a lot of those. So relevant illnesses is big. What have they tried for non-pharmacologic strategies and effectiveness? There's a lot of really neat things out there that don't involve a prescription. If you have a relationship with a good pain physician nearby, it's always worth running by. Like, hey, what do you guys? We're looking at this. I'm really not looking to escalate. It may be something as simple as dry needling. It may be acupuncture. It may be an epidural. Maybe an ablation. I had a guy this week that's had chronic facial pain for years. I started something, we did a trigeminal nerve block, and it worked well for him. And we just did a pulsed RFA of his trigeminal nerve, and that's helped Kevin bring down his pain a lot with facial pain. So just ask. And the big thing with pharmacologic strategies, on the medical side, please do a good job making sure that you understand what other meds they're on. I think even more than our own charts, look at the state's prescription monitoring program. That can be really helpful with seeing even quick changes. Maybe they got a Valium or a Xanax for a dental procedure. Maybe they were in the ER 3 or 4 days ago and got a prescription there for a week. Like, just check that. It can also be a good clue in that maybe the patient forgot to tell you about a surgery or hospitalization. And then any barriers to prevent treatment strategies. If a strategy was ineffective in the past, why? Maybe it was like let's take an example like pregabalin, right? 5 years ago, that was hard to get anyone on, and now it's generic. So a lot of those barriers get broken down with time, life changes that we can do. Maybe they're on a different insurance plan this year. PDMPs, you guys are all very aware of. This is not new to anyone. Utah does a pretty good job of having it updated. I believe pharmacies still, they'll get 2 weeks to put it in. And the smaller the pharmacy, I see, at least in my clinic, I often see the documentation quality goes down. So, go ahead. Correct.
But it also was associated more with a certain pharmacy than others.
Correct. I would agree with you guys have probably seen that, right? There's certain pharmacies that I have. I'm like, they just don't record it. It's not right. The date's wrong. I've seen the quantity wrong.
When I called them and mentioned this, they gave me a lot of pushback.
Yes, they do.
Said, it's a problem with Intermountain stuff.
Yeah.
And I'm not seeing that a problem with Intermountain stuff is going to make a problem with one pharmacy.
Agree. It would cause it with all pharmacies, and if there is a problem in mountain stuff, let me know. I'm the guy that would either screw that up or make it be okay. So let me know. But yeah, I agree. I have 2 pharmacies in Utah Valley. I have one girl. I saw her on. I saw Amy on Wednesday, and they haven't put hers in since December. And this is something I call and say, hey, can you just confirm this prescription? It's always the worst patients, or they're on the highest doses, and the pharmacists are always the angry at those ones places too. So yeah, and I've seen it where either the quantity's been wrong, the date's been wrong, I've had the medication be wrong. So although it's a great system, it is in no way fail-proof, and trust your gut, because I've had that. I think all of us have had that happen. So again, check for other co-prescribed meds. Check for recent hospitalizations or ED visits. If in my practice, this is a personal choice. If they've had an ED visit or a hospitalization or a surgery, and they forget to tell me, I'm fairly forgiving there, but I want to know about it. And I do remind, like, just let me know. You know, but a lot of people just in the hustle and bustle of something big in their life happening are so stressed about some of our appointments they forget to tell us. Then I also let them know if they have procedures that are elective to let me know, and I can help take over those pain meds afterwards. We can kind of keep it down to one prescriber. This is also a great way just to make sure none of your patients are pulling the proverbial like wool over your eyes. When I first started here in Utah, I had a couple come in. They're on the same med, the same dose, same pharmacy. I was like, I don't see this very often. It's a little sneaky. So I pulled their PDMP, and one of them had 23 aberrant refills over 3 months, and the other had 26. And they were essentially going to different dentists and ER docs in different systems. This would have been 2019. And so I don't discharge patients from my clinics, but I will stop prescribing pretty quickly. And that's what I did there. we're happy to give you non-opioid treatment. But if the PDNP wasn't there, I wouldn't have caught it because they were pretty slick about it. So, and the last line, multiple opioid prescriptions from multiple physicians is always a red flag. It's either a red flag that someone's not owning this person's care, or it's a red flag that this person is seeking care to get an opioid. And I've seen that happen from 20-year-olds up to 80 or 90 years olds, and so just age doesn't really matter, condition doesn't matter, but it is a red flag. You guys are all very familiar with Doppel. Those of you at Intermountain, it's built into your web system. Those of you that are not, I used to use a delegate a lot when I was in Texas, and my MA would have that printed off before I would go into the room. They were on an opioid. As a pain provider, I check that every visit. In primary care, everything you guys have going on, choose a cadence so it becomes repetitive for you so you don't miss it. The PDNP has saved me more times than I care to admit in making a good prescribing habit. And then the reporting you see there, we've already talked about that. It's good. It's actually probably good to great, but it's not perfect. And yes, if you call a pharmacy on it, you'll probably get pushback. The post was blocking. I'm sorry. Correct. Yeah, federal facilities don't have to report. Yeah, it's weird. Correct. Yep. Which to me is kind of interesting that it's a federal initiative run by states, but federal places don't have to put it in. When I was in San Antonio, that was a big issue because we would do overflow for the VA's pain clinic and their primary care, but we wouldn't know. We couldn't get access to what they were on, and it wasn't logged in the state, so it was just going off trust, and that burned us a fair amount, unfortunately. So, yeah, agree. We've talked about this. On this one, I'm going to highlight these top ones here. These are just examples. For a psychological history, if you're running, if you do a lot of chronic pain, I would look at the PHQ-9 and the GAD-7. Those are great screening surveys to look for mental health, especially anxiety and depression. There's not one that's great right now that looks at PTSD, in a silo. I would recommend most people, if you're not doing a lot of chronic pain, use the PHQ-2, and if that ends up being positive, you can go to the PHQ-9. It's nice to document, not so much on an initial visit, but trending that has been very helpful. Like in Lisa, who I discussed, we could see that go through like that. We use a Promise 10 in our clinic, but I love to trend those because then you can watch and see if that depression, anxiety, or PTSD starts to really morph into this big melting pot of chronic pain. We don't currently use the history of adverse childhood experiences. We do screen for trauma, both on our forms, and I'll screen subjectively. It comes up more times than I ever think, and it's again not based upon how you may perceive a patient. It happens in all patients at all times. And I don't know if you guys would agree with this, I see it actually more like remote trauma comes up, like something that happened in their childhood or their teenage years or early part of adulthood. I often don't see a recent event it's usually something that's been buried in the past, and then they've had a chronic traumatic event that's somehow kind of unearthed that. And sometimes that comes up when you actually get them good psychological help as they go through that. The social determinants of health, very, very well. As the determinants of health get worse, chronic pain gets worse, opioid use gets worse, and opioid use disorder gets worse. And I would say that's not because of the patient, it's because whatever health system they're in, we're not meeting that patient's need. And obviously it presents the same challenges, whether you're a primary care doc at the ER or a pain clinic. But these have huge impacts into chronic pain development just because they're having a lot of other chronic diseases that probably promote and amplify the ability to get chronic pain. So with opioid use disorder specifically, just like that PHQ-2 is like a super handy quick tool, the ORT, OUD is really good. It's a pretty simple tool. There are lots of tools to assess opioid use disorder. Some of them are several questions long, 20, 30, 40, 50 questions long. I would not recommend that in your in addiction medicine, chronic pain, behavioral health. So the ORT OUD is good. The DAST is a general tool for drug abuse. And then you have the NIDAS self-single question screening test. None of these are better than the TAPS there as well, actually. None of them are better than the other. If you have an interest in your clinic, I would look at it and see what works best with your workflow. The ORT is probably the most efficient. And so here's an example of the ORT OUD. And then less than 2, it's got like a really, really low screening threshold, as you can see. Like if you're above 3 or more with those nine questions, you're already going to be in the high risk group. So very low screening. And you could use this, the ORT, to go on to like a DAST or a Promise 29. I would say if you're not doing chronic pain or addiction every day, I would use the ORT OUD. And if that's positive, consider it, getting behavioral health, psychiatry, or addiction med involved if they're in that area. But you can see here, this is nothing that you guys wouldn't already think of. Other substance use disorders amplify the risk of getting opioid use disorder. We have a history of illegal drug use of either illegal drugs or prescription drugs. The earlier the age, the more likely, and obviously coexisting psychological disorders. Physical exam and assessment, we could do a whole week on different physical exams. But generally speaking, start off what you do any place else. What's their general exam? What's their appearance? How are they speaking to you? How are they walking? If you walk your patients back, how are they sitting? Are they offloading part of their spine? There's the infamous migraine patients with the lights off and their sunglasses on, right? Kind of like how do they generally look? What are their vital signs at? Especially the younger the patients, if you got like pediatric pain, vital signs, especially a change from normal, especially like heart rate or blood pressure, can be a good sign there's acute pain. Chronic pain doesn't really kind of change day to day because it's chronic. Their bodies are now adjusted. Neurologic exam is probably the biggest one where I would say this allows you to assess how quickly does this patient need surgery, emergent assessment, or do I need to escalate imaging care? And that could be something as simple as they have a positive Babinski exam. And we're worried about an upper motor neuron center. They have a Hoffman's exam. Their gait looks abnormal. And any of the cranial nerve deficits are obviously right for issues. I had a lady we took care of. She fell 4 years ago in her bathroom. She hit the back of her neck. And then when she hit the back of her neck, she bounced forward, hit the front of her head. And so she came with mostly neck pain or what we call facet pain. Neurologic exam was normal. She went through physical therapy and the neck pain didn't get better. Actually, Dr. Romankowski did her cervical RFA. She did about 50 to 60% relief with it, but still had this ongoing pain right here. She was on her right side, right frontal temporal region. And then she started to have vision changes, and I noticed her ocular muscles on the right eye weren't moving as well as the left. Everything else was better, and so we MRI'd her brain, and she actually had a neuroglioma sitting on the brain that was there, not causing symptoms, but over the course of not improving, through this 9-month course of PT, neck pain, RFA, those symptoms have gotten worse, and so then she had it excised, and now she's doing very, very well. So that neurologic exam is really huge in identifying red flags, yellow lights, and how fast this patient can go in. And musculoskeletal exam, Chris is probably the best person in this room to do musculoskeletal exam, but we're big MSK fans as physiatrists, and in pain medicine. Often what is the neck is the shoulder, what is the back is the hip. There's a lot of issues in both rotator cuff muscles of the shoulder that can look like neck pain, look like it's radicular pain. In the low back, that overlap of lower lumbar disease, sacroiliac joint disease or dysfunction, and then gluteal issues get missed all the time. That's another great way. Even if you get a patient that's like, I've been to physical therapy 5 times, do not send me again. And you can't really, like, there's something here, it doesn't look back. Be willing to send them once or twice to the physical therapist and call that physical therapist and say, I'm really, man, can't tell if this is a gluteal issue, like a nerve palsy. Is this SI joint? Is it facet pain? Is it both? All the exam tests are positive. Is the patient just trying to get me to sign their disability papers? All of these things go through her head. Work with a physical therapist. Have them look at it. They get in almost 30 minutes to an hour to assess. Thought we had like a Tanner Clinic person here. Like Tanner Clinic PTs are great. I bug my PTs a lot when I really can't feel like I hone in on a diagnosis. I'll say, can you see them just for 1 or 2 visits and let me know what you're thinking? And that can often help where you go with either procedures, surgery, if you're doing exercise prescriptions, what you want them to do. I'm old enough, and some of these gray hairs are earned. I'm a big fan of palpation, percussion, and still listening to lungs. I think you would get a ton off of physical exam. It's especially helpful to differentiate between like musculoskeletal tissue pain stuff that may be deeper, like facet, vertebral, like a vertebral body fracture. It's great with SI joint pain. I use it a lot to let me know, is this a spinal issue or is this more of a limb issue? So I'm a big believer in that. There are hundreds of provocative maneuvers. Some of them are great, some of them not so much. My favorite is the SI joint. The SI joint, I think, has 17 or 19 maneuvers you can do that all have sensitivity and specificity for it. And the best one is called the Fortin finger sign, where the patient takes their index finger and they point over their SI joint. And so I say that in jest to know that provocative moves are extremely helpful. They're there to screen and guide, but they're rarely confirmatory. So that's why I don't cast them aside, but I also don't put all my eggs in that basket. And every area of the spine has it. And I'll remind you, the neurologic exam, though, is really where you can keep you and your patient safe. That's like if something's positive here, get the imaging ASAP and potentially get them into the ER. And they can also be very helpful to knowing where to go next with imaging. Okay, and then in Norm's case, you mentioned a little bit of neuropathy, and I'll end on this point. Cutaneous or trophic findings. My guy on call, sorry, I'm something to watch. We get a lot of people that non-painful physical exam maneuvers will generate pain. In some cases, that is malingering. In other cases, it is fibromyalgia. But in other cases, it's actually signs of neuropathic pain. And so especially if it's in a hand or a wrist, a foot or an ankle, an extremity, the face, should start to clue you into maybe something like complex regional pain syndrome, maybe a mononeuropathy like a very hyperalgesic carpal tunnel syndrome. And I only say that because we end up seeing a lot of patients where people think they're malingering, it's psychosomatic, it's fibromyalgia. We end up finding out it's actually something very, very different or unique. So even the cutaneous findings of non-painful stimulus causing pain can be really indicative, like this needs to be worked up, especially if they've been seen by a lot of providers. And but yeah, and then there's a lot of different treatments we can do for that. But I'll leave it at that, and then I'll give it back to Norm to see if he wants to add anything to this. So actually, it was Josh. It's been 2 years. It's been too long. So this is Dr. Minori. Dr. Minori.
I'm going to take the podium here because I appreciate a little stability while I speak, and I'm not as charismatic as Norm and Dr. Benfield, so I apologize ahead of time for that. All right, that should be, can everybody hear me okay right there? Good? All right. So I'm going to start with chapter 3 here, and I like to just kind of start with some objectives a little bit, like what we're going to kind of trying to be learning here as we go on. I really want to talk about applying assessment results and using those to create an individual treatment plan that does include functional goals, and I'll harp on that a lot. We all have so far today. We want to identify evidence-based, non-pharmacological options. We're going to identify non-opioid approaches. We're going to align treatment approaches to a specific type of pain. So we'll be talking a little bit further about what Norm touched on in chapter 1. And we're going to correlate precautions and considerations for opioid use in different populations. We'll identify common adverse events and drug interactions with opioid use. And we're going to take some time to look at characteristics that may influence your choice of a specific opioid. So with this slide, I mean, it's kind of a 30,000-foot view, and it really harps on a multimodal treatment plan. And we really should be developing these and customizing these to each one of our patients. The goal of treatment, obviously, we all look to try to expect an outcome of pain reduction, but you know, as a physiatrist, more important for me is that improvement in functional outcomes impaired by pain. I took out all the pain, you know, 0 through 10 out of all my offices just because I don't like that. I want to know about functional gains, activity of living, and then also quality of life. And we really want to consider first looking at non-pharmacologic and or non-opioid therapies. So looking at evidence-based pharmacological treatments, regardless of the type of pain, all these approaches should be considered. They have been found to be effective alone, or more importantly for me, I think of them as part of a comprehensive management plan, particularly for musculoskeletal, neuromusculoskeletal, or chronic pain disease states. Some of them obviously are more applicable for some conditions, but the options that are listed here are all worthy of consideration, and there is evidence to support all of their efficacy. So, yeah. Yeah, that's acceptance commitment therapy there. And then osteopathic manipulative therapy as well. We have some DOs around here that are still doing a lot of that good work. So, and then this slide, I'm just going to kind of get some of this stuff up. This is coming back to Norm's slide a little bit. It was discussed in chapter 1. And I'm going to add a few things to his, to some prior information, just kind of looking more at treatment options here. And just one note, the medications listed at the bottom there are in alphabetical order. It does not imply preference, all right? So with this, I'll kind of talk a little bit about the nociceptive category, and I really want to point out one thing on there with topical pain medication. I think this one's overlooked a lot of the times, but can be really helpful as low-hanging fruit for some people, and risks aren't as high as some of the other therapies. And looking into your compounding pharmacies, just being aware though that each pharmacy has different prices for different things, okay? I spent a lot of time when I first moved here calling around at different places with the same order to say, what are the prices? So I try to do that every so often just to stay on top of that, and patients will advocate for themselves too and do that as well. But the nice thing about some of the compounding pharmacies is for different types of pain, you can add in different medications to treat those. You can take things away as they progress through their treatment plan. So it can really tailor those medications to an individual patient's needs. And I'm going to skip over nociplastic for right now and go to neuropathic. I'm not going to go into each one of these in detail. Just want to highlight here where if you are teamed up with or know a good interventional pain specialist, this is where we can really look at some of these interventional therapies to go after both peripherally mediated and centrally mediated pain. So for nociplastic, this, and I'll add to Norm, he did an awesome job with this, but it's really pain that arises from an altered nociception despite no clear evidence or actual threatened tissue damage or evidence of disease. It's multifocal and widespread. You have augmentation of the central nervous system, pain and sensory processing. You have altered pain modulators. You get amplified pain signals. You have expansion of the receptor fields, and you have this decreasing descending modulation or regulation of pain. One thing that's highlighted, and they say no opioids for this category. Really one example is patients with fibromyalgia. We found through a lot of research that they have reduced mu opioid receptor availability within the regions of the brain that normally process and dampen pain signals. So we see that a lot in these states. So this is a very busy slide here. Just basically, before we prescribe, we should take all of these characteristics into consideration, okay? The FDA, there's a website at the bottom here. They have compiled prescribing information for all opioids at the website shown above, or for there. And just be aware, one thing on here I'll highlight too is patients with hepatic, right, or renal issues often need a reduction in strength and dose. So just always be aware of that. And here, this is just kind of going through a few things about shared decision making, and it's very, very important. And I mean, we all understand this, and it's all intuitive. Just like the grass is green and the sky is blue, but it's nice to kind of go through it every once in a while. You want to partner with your patient and discuss the clinical issues, go over pros and cons. And the big thing I think to highlight is really assess a patient's understanding. It takes a lot of time, but assess their understanding throughout the treatment plan of the therapies you're considering. So when to consider a trial. These recommendations here in the boxes for when to consider an opioid are completely in line with the CDC guidelines. We should consider all pain management options and prescribe opioids only really when non-opioid options are inadequate or when the benefit of an opioid may be expected to outweigh the risk. I like thinking about this as a therapeutic trial. So building in expectations at the beginning with your patients. just understanding that, we're going to try this medication for a short time. If it doesn't work, we're going to stop it, just as you would with any other medication you'd prescribe. And really important to define work. What is work? Is it just reducing pain from a 7 to a 3? Again, I don't think so. It's part of it. But you must determine your goals with your patients. Kind of we're using the medication to achieve blank. And looking at functional gains, quality of life, improve ADLs, write these down specifically. Specific examples for each patient take time to create, but it will save you down the road. And you can look at these as they're progressing through treatment plans. Like John said, his patient that he mentioned earlier, just looking at pain, 7 the whole time, or you're on this roller coaster ride. But if you document changes that patients forget about and you bring them up later on and say, look, you're now able to sit through a movie with your family still. That's showing some benefit here. And it kind of, I think, hits home a little better than just, now it's a 4, now it's a 3, now it's a 7. Flip a coin. So very important. Okay, so with this slide, risks versus benefits. Very, very important to fully consider all the risks listed using opioids prior to initiating them. There was a study back in 2018. It was a systematic review and a meta-analysis of 12 studies. They were looking at the incidence of new cases of opioid use disorder after treatment of prescribed opioid analgesics and found it to be almost as high as 5%. So that's pretty significant here with this population. There are benefits, though. There are benefits. I don't want to this isn't all doom and gloom, too. They are effective analgesics for acute severe pain. Patients who are unable, again, to take non-opioid therapies, you may consider this. Relieve suffering, especially at the end of life, and can improve function in certain conditions. Okay. So jumping into categorization. So here is a list of all the opioids that fall into which categories. There's not much to really go into here. It's more of a kind of, a lot of you already know it, or if you want to take a picture of this. There is a QR code, though, at the top right there that you can have access to these slides down the road, too, and look into that. And that refers to the DEA drug schedule there, where you can find a lot of information here. So it's just kind of more of a resource slide. So I'll just kind of leave it hang up there for a second or two here. Yeah, Chris. Yeah, I mean, it's kind of that gray zone, with tramadol, and especially with its effect, like we'll talk about later on the mu receptors and the serotonin benefit of it as well. So yes, I've been told that as well. I think that's kind of been a little bit possibly debunked, but John, if you have any other. That was a while, like. Correct. That was, back, same thing. I think we all know. So just looking in side effects here. So on the left side are items that are known and acknowledged to be common side effects. The right side, however, adverse events and serious medical consequences. Opioid analgesic, these medications carry significant risk, and we all know a lot of these risks are not present with other non-opioid analgesics. So risks of misuse, addiction, which we've been talking about, respiratory depression, overdose, death. And just to point out here, it's highlighted in red there and flashing that opioid-induced constipation is the most common side effect of opiate therapy. So just be sure to have something in place, mitigation strategy for this. It's really important. And it is all of our responsibilities to be knowledgeable about how to weigh these risks before prescribing an opioid and how to properly manage patients who are prescribed these opioids, both short-term and long-term. So I want to jump into this opioid-induced respiratory depression. This is the number one most life-threatening situation when it comes to prescribing opioids. More likely to occur, we think about elderly patients. Also, other drugs that depress respiratory drive, specifically benzodiazepines. We look at this for patients who may be opioid naive, so someone going into surgery who's never been on an opioid before, or people who have been on opioids for a while, and you may be changing dose for whatever reason, or increasing the dose. Also, patients with other respiratory conditions, as many as you can think of. You always want to think about that, but obviously obstructive sleep apnea is a big one here. And the greatest risk, again, it's up here a few times, is combining it with benzodiazepines. So also kind of how to reduce it. One highlight here is don't overestimate the dose when you're converting dosages. We'll talk about that a little bit more later in detail. I'm not going to go into that more, but just a very important point up there. Again, staying on this subject here, make sure, please, looking at distributing, dispensing, prescribing naloxone to patients and caregivers. Okay, it's very important to educate patients about this and caregivers because it can save lives. Again, this is the #1 most life-threatening situation. We want to educate our patients, family members, caregivers about the signs and symptoms and how to seek help. You may see just sedation at first, and that can rapidly progress to respiratory depression. So ensure patients, family givers, caregivers have access to naloxone. Many people, unfortunately, do not fill this, and I will touch a little bit more about that later on here. So this slide jumps in more education, but signs of accidental opioid poisoning. And you can kind of take some time to read through that there. The big thing there, call 911 and administer naloxone. This came up before, I think, 3 years ago. What do you do first? There's no answer to that. Sorry, you can't give it. Whether to call 911 or give naloxone first, it's just dependent on your situation. Just get those things started ASAP. You can't have a one-size-fit-all direction in these situations, so don't try to think about that ahead of time. There was a study from 2005 to 2018 through Children's Hospital in Philadelphia. It was a 14-year period, and they found that 47%, almost 50%, of all fatal poisonings of U.S. toddlers were involved with opioids. So segue into more education and naloxone options. Naloxone, or what we know as Narcan, it's an opioid antagonist. It reverses acute opioid-induced respiratory depression. So this allows someone who's overdosing a victim to regain consciousness and breathe normally. But again, remember, it will reverse the analgesic effect, so it can cause some withdrawal from the opioid itself. Typically, nasal administration, sometimes intramuscular, those two, you can actually find a lot of videos on YouTube on how to administer. So I talk about that with patients too, like, I'm not sure how to do this. We have the web and a lot of these great videos. So find one that you like, and I'd say use it. Again, naloxone works by displacing the opioid from the receptor, which is very important thing to keep in mind. It is most commonly used for the nares, but it can be used intravenously, intramuscularly, subcutaneously, and there is mentioned specific situations that call for naloxone prescribing, and you can find this, but I personally recommend that anytime you prescribe opioids, just prescribe naloxone. Specifically to Utah, this was effective date way back now, 2017, and just kind of goes through criminal immunity, also available, carried by first responders. Immunity itself protects the medical professional from liability for prescribing and dispensing naloxone, as well as lay people for administering it when needed. When they talk about third party, that means that's a person who's not at risk for overdose. That's family members, bystanders. And then a standing order, this is a physician order that can be carried out by other healthcare workers when predetermined conditions have been met. Just kind of clarify some of that information in terms. Okay, so for safe use here, we all know pharmacokinetics that's the movement of the drug through the body, and then pharmacodynamics refers to the body's biological response to the drug. So looking through some of these things, really important that some opioids, be aware, can prolong QTC intervals. So you want to be checking that regularly, specifically methadone. And here we look at tramadol too, with its possible serotonin syndrome effects. So when looking at tramadol, it's a mu receptor, but it's combined also with serotonergic effect, like SSRI. So thinking of things like monoamine oxidase inhibitors, and you're combining these, you can set yourself up for this serotonin syndrome pretty easily. So just be aware of that. That's just the point to make there. Slide here, just drugs that inhibit or induce CYP enzymes. You can look through this. This reiterates, again, this underlying theme, the importance of knowing the product-specific information before you prescribe, okay? Just consider all effects of other medications the patients are taking, okay? And just do some due diligence there when you prescribe. So here we'll go into forms, and specifically transdermal, transmucosal, and these are some special considerations to consider for this delivery method itself. Obviously, we always say do not cut, chew, or swallow. Be aware also that you can get an increased dose exposure with temperature as well, so heating. So patients, we tend to say, please avoid like a hot tub, a sauna. You know, it's put on my shoulder, but I put a heating pack there. Careful of that. And then also some of the metal foils in the backings may not be safe for some imaging, specifically MRI imaging. So there's pretty good information out there on the label, and you can look through websites to find out which is which, but just be aware of that. So we'll jump in here for medication for use for opioid disorder. There is no real recommended time period for treatment or reduced mortality for this. More importantly, it is really to be individualized to a treatment plan and not following best practices. This is not how we would use opioids for chronic pain, where we look at best practices and try to really stick to that. This is specific for opioid use disorder, so you really got to tailor it towards that individual treatment plan here. Patients with opioid use disorder, that's really important here, they have decreased mortality when treated. So relapse rates are in the 90% range over time in those patients with opioid use disorder who decline pharmacotherapy. So medications for opioid use disorder can be associated with improved treatment retention, lower rates of opioid use, improved social functioning, decreased injection drug use, reduced HIV, HCV transmission, and better quality of life. So it is important that we think about treating these patients. Anyone with a DEA license can prescribe buprenorphine. You never really needed an X waiver to do it for pain. That was more for opioid use disorder. That's since changed. Specifically with methadone for opioid use disorder treatment, it still does require access in federally regulated opioid treatment programs, but you can use methadone for pain through regular pharmacies. Now Trexone up here too. That's an opioid antagonist, and it's both approved for alcohol and opioid use disorder, but it's more effective for controlling the cravings for opioids after a period of detoxification. So you're really looking at that to help prevent that relapse period. So that's important. And again, common misconception, right? That medications are merely a substitute for one drug or one addiction for another. We're not feeding an addiction here. We're actually treating an underlying disorder. Okay, so we're going to jump a few slides here talking about buprenorphine now. Buprenorphine does save lives. You know, people with opioid use disorder are 50% less likely to die when they're being prescribed long-term either buprenorphine or methadone. There was a CDC stat from 2022 that only 25% of patients are offered medication specifically for opioid use disorder. And one thing about buprenorphine we all harp on with its safety profile is the charts you see at the bottom with this plateau effect for respiratory depression. One thing to keep in mind is that you still need to co-prescribe Narcan for this. Even though naloxone may be combined with the buprenorphine, it's not active unless it's been altered and used as an injectable. So please still prescribe Narcan if you are using like a combination buprenorphine naloxone product, okay? Major features of buprenorphine, it does treat withdrawal, cravings, overdose. It is safe and effective. Caveat here that most of these products dissolved in the mouth, so just take extra steps to help lessen dental problems. So after the medication's dissolved, we kind of tell people to take large sips of water and swish it around in your teeth and your gums, and then patients should wait at least 1 hour before brushing their teeth. That can help decrease the risk of damaging teeth long term, okay? Okay, yeah. You could if you take it like before, like an evening dose, and you brush your teeth in the evening, just tell them to wait to brush their teeth an hour. So they'll brush their teeth an hour after they take it, not before they take it or 5 minutes after they take it. So just tell them, you know, if you take your medication, sorry, but you can't brush your teeth for an hour. So that's usually what I kind of say. And then with this slide here, animated slide, I'm going to bring them all up at once. So buprenorphine itself, you can kind of look through these. They go left to right, top to bottom. It's a partial opioid agonist, which has a high affinity for the mu receptor and outcompetes with other opioids while maintaining a ceiling effect on respiratory depression. So as a partial agonist, buprenorphine has a limited opioid effect, but it is enough to stop withdrawal, and it does provide analgesia, but it's not enough to hit that euphoric feeling or that euphoric high that gets you into that washing machine, patients into that washing machine cycle. So it's just a really important point with this product. This slide I'm a little scared of when I first saw it in here, just for our purposes now. This slide, I showed this to my clinical pharmacist, and she's like, man, you could talk about that for an hour. And so it's a little outside of this, but we're going to talk, this is an example of microdosing or kind of micro inductions, and it's somewhat nuanced, but it can be a good option for patients with opioid use disorder and also chronic pain itself. There are multiple method options. There's options like the Bernice or the modified Bernice. This is an example of microdosing buprenorphine from the VA guidelines on chronic pain. If you do have clinical pharmacists, a lot of us don't, or if you know people, talk to them about this. They have a wealth of information. I talk about my clinical pharmacist. We talk every week, almost every day. It's important with this, though. I think the overlying theme here is the lowest effective dose of buprenorphine should be maintained and can be maintained. Should patients stabilize, meaning maybe they don't have any more withdrawal, their pain is tolerable before reaching these upper or more proposed end doses, it's not necessary to proceed. You can keep them at that dose. And it doesn't need to be tapered down the line. It can be effective and it can be maintained long term. Okay, so last kind of little section that I have here, we're going to jump into some special populations. The first we're going to talk about is kind of substance or opioid use disorder patients. These patients, kind of coexisting pain and opioid use disorder, I think we all know, can be some of the most challenging patients we encounter in our practices. You really want to consider a multimodal pain program, multidisciplinary pain program. We've harped on that for every patient we see, but more importantly for this population. Enlist family members, caregivers, kind of to help administer or secure medication, and really look at the PDMP and screening methods, but not as a way of pointing fingers, but help educating and showing and getting people over hurdles that may be struggling. Sorry, I wanted to go back to that here. When appropriate too, I know you might want to consider also in this, or maybe have a lower threshold to refer out to a specialist if it's outside of your comfort zone. I do recognize that kind of referrals can take a while, and we have limited specialists around the country and even in Utah. But we do have, I think, some people getting into the field of addiction medicine and addictionologists, and hopefully we'll see that grow. And if you have colleagues like that, just reach out and refer and get that team approach with them and their expertise. Okay, so we're jumping in here to another population, somewhat complicated in a way, women with childbearing potential, and kind of relying here a little bit more on the American College of Obstetrics and Gynecologists. They really recommend for women taking opioids daily, buprenorphine or methadone. They recommend universal drug screenings for substance use as part of the obstetric care, and really think this should be done kind of at the first prenatal visit. Potential risks during pregnancy to the newborn are quite significant and severe, and they include low birth weight, premature births, hypoxic ischemic brain injury, neonatal death, prolonged QT syndrome, and neonatal opioid withdrawal syndrome. And opioid withdrawal syndrome can be expected into up to half of the newborns born from opioid-dependent mothers. So very significant. Okay, just kind of coming into an older adult population, the complexity of managing care in older patients with persistent pain does again call as well for a multidisciplinary approach. I believe older patients, they may have a lot of medical problems or comorbidities that increase the risk of adverse events. Respiratory depression, like we talked about before on one of the slides, is more prominent here. and also altered pharmacokinetics due to poor fat stores, muscle wasting, altered clearance. They're more likely to develop constipation, so you should have a bowel regimen set up, and polypharmacy, really thinking about polypharmacy causing falls or cognitive changes. So it's very important here. Jumping to the other end of the spectrum, now pediatrics, okay? The American Association of Pediatrics actually released some new guidelines in 2024 on opioid prescribing for acute pain management in children and adolescents in the outpatient setting. They do recommend not prescribing opioids as monotherapy for acute pain and trying to avoid codeine and tramadol in most situations. The safety and effectiveness of most opioids in pediatric patients below the age of 18 has not really been well established. Most of these agents are not indicated for pediatric patients. A lot of non-clinical studies examining opioid use in children really focused on an inpatient setting and not an outpatient setting. And, you know, pediatric indications for chronic pain with opioid use, primarily with life-threatening conditions. So few pediatric patients with chronic pain due to non-life-limiting conditions should receive long-term opioid therapy. The last slide kind of combines a few other, special, we're going to get to the next one. Sorry. If there was any additional information you want to look at, but I think we kind of covered most of this stuff here. That's what you get for being at a podium. But the last thing, we'll talk about a few others here. People with sleep disorders, try not to prescribe opioids as a sleep aid medication. I think that's all intuitive. Very cautious with obstructive sleep apnea. And about 2/3 of patients, which is really high, who suffer from chronic pain also report poor, non-refreshing sleep due to their pain. However, the problem is pain and sleep is complicated because opioids can fragment or break up sleep itself, the sleep cycle. So, and if patients experience poor sleep one night, they're more likely to experience more pain the following night, and then they're in this chronic, or following day, they're in this chronic cycle. I'm going to go back. Patients with dementia or impaired cognition, know that your evaluation, your pain evaluation can still be performed, but it's going to be less reliable. Try to listen to your intuition with these patients and anticipate. Sometimes it can manifest, pain can manifest in just behavioral findings or agitation. Another population, we look at kind of obese patients here in pain. I find this kind of interesting because when you talk to orthopedic colleagues or you're getting knee replacements, it's always, you know, lose weight to take stress off the joint, the mechanical force. But actually, pro-inflammatory cytokines, specifically interleukin-6, is found at very high levels in adipose tissue. So you can actually lower your body's inflammatory state. And I kind of give the analogy of, you know, in the Uintas, if Smokey's bears arms on yellow, you know, light a little campfire, you're not going to burn down the whole forest. But if it's on red, a little fire could destroy everything. So if you're running at a high inflammatory state, even a little injury can wrap you into this chronic ongoing pain condition. I also look at, too, mechanics of the spine, doing a lot of spine, and a thing we call sagittal balance. So it's the space, our body, our spine was designed with these awesome curvatures to dissipate forces. And if our sagittal balance changes, one example, women who become pregnant and carry a lot of weight out front, if that happened long term, they put a lot of other forces on different parts of their spine that weren't meant to have that. Within a few months, not a big deal, but long term, years and years, that's where you can get into the chronic degenerative disease states, degenerative disc disease, facet arthropathy. So it's really important to kind of highlight those aspects as well when you're talking about weight management, I think. Renal and hepatic impairments. Active toxic metabolites of many opioids are renally excreted, so accumulation can occur if these organ functions are not functioning well. So that's where a patient can have an opioid overdose when taking a medication exactly as prescribed. They could have something underlying going on you're not aware of that's affecting their liver or their kidney, so it's an important point. And then psychiatric substance use disorder. We all know that these conditions and pain management issues are kind of comorbid conditions itself. A highlight there in that population I always think about is drug interactions and that development of serotonin syndrome. So SSRIs, SNRIs, tricyclic antidepressants, be always thinking about that. And again, more than 30% of overdoses involve with opioids, benzodiazepines. Okay. End-of-life population, again, not much to say here, just involvement of hospice, palliative care medicine should always be considered early. And I think that is all I have. Sorry. So I'm going to turn it over to Joy now and kind of step away from the podium here. Thank you.
All right. Do you guys want to keep going, or does everyone want to have like a 5-minute break? Take a break? Okay. All right, we'll take 5 minutes then.